it gives me great pleasure to welcome Dr. RAINA MACINTYRE back again. Last time she presented was December 2020, and that was on the transmission of SARS-CoV-2 implications for work health and work safety and health. I'll put a link to that presentation in the chat box, and it might pay for people on this webinar to look at that as well, because that really kind of set the stage, so to speak. And yeah, so I'll give you RAINA's Dr. MACINTYRE's background. She's really, an expert in infectious disease outbreaks, and because she's also the lead of a global biosecurity. When our webinar committee were talking about, what webinars do we need to provide, and Audrey Cunningham said it would be good to do a recap on COVID. And so we kind of scanned all of the different presentations, and I thought, well, because Dr. MACINTYRE's got this kind of global perspective on COVID, she's probably the best one to have come back. And there's been some things that have happened since. So she's the National Health and Medical Research Council, a Principal Research Fellow. I said she's in the Global Biosecurity Program at Kirby Institute. Her main areas of research are personal protective equipment. She's done a lot of work in respirators, comparing respirators and masks for decades, vaccinology, epidemic response and emerging infectious diseases, and bioterrorism prevention. If you have a look at the link on my presentation, the Kirby Institute, I'd be here all day if I was to kind of go through all the different committees that Professor Dr. MACINTYRE is on, and but she, 21% of her papers are in the top 10% most cited papers, and one of the interesting things that I noted was that Dr. MACINTYRE actually studied the transmission of TB in prisons in the US, which I thought was quite interesting as well. So I won't spend any more time on the bio. I'll just share my screen now so we can go to the title slide here. And so you can see that what RAINA is going to be talking about is a review of pandemics and biosecurity over time, insights for prevention and response. We have a YouTube channel. Workplace Health Without Borders has a YouTube channel, so you can click on this hyperlink here and you can see all of the presentations. But for all of you newcomers, please consider joining WHWB. I want to do a land acknowledgement moving forward. I would like to begin by acknowledging that I am speaking from Ottawa, Canada, to all First Nations, Inuit and Métis peoples and their valuable past and present contributions to this land. As I am in Ottawa, I am located on the unceded territory of the Anishinaabe Algonquin Nation. I always like to show this slide just to give you a bit of a overview of Workplace Health Without Borders. This is our strategic framework document that was revised and reproduced in January 6, 2021. But with our vision, we broaden our vision for workers, their families and communities, as well as workers, and the mission to prevent work-related disease and injury through the sharing of expertise, knowledge and skills with underserved populations wherever needed throughout the world. We're a global network of concerned professionals. We're very passionate about the work we do. We're volunteers, and we want to share our skills towards the prevention of work-related disease and injury. So membership's open without restriction to anyone around the globe. If you do look at the YouTube channel, you'll see that there's a lot of COVID-related webinars. So basically what I've done here is I've just organized them by, the years that they've been running. So, really not that far from the start of the pandemic, we started to run webinars. So we've had Professor Joseph Allen, Lydia Maraska, Lisa Brossu. Very honoured to have Dave Zork, who's on the board of directors, talk about control banning, applying control banning to COVID as well. We've had speakers from Australia, Nigeria, and also from the WeGo group, Waste Workers group. There's just kind of like a bit of an idea, just having a look at the screen there of all the presenters. And you'll see at the top of the screen there, this is the one that Dr. McIntyre provided back in December 2020. And just the bottom right-hand corner there, there's just Dave Zork talking about the control banning approach, thinking about looking at, traffic lights with regard to, stop or be cautious or go. And it'd be remiss of me not to mention the Canadian Aerosol Transmission Coalition. So when you look at this website, you'll see there's materials here as well. We did provide Mask Smart 1, Mask Smart 2, Mask Smart 3. Simon Smith is on the webinar. He's a Canadian respiratory protection expert. He's also leading the revision of the Canadian standard as well. So it's great that Simon's on as well. I'm employed full time. My full time position is with the Occupational Health Clinics for Ontario Workers. And so what we're going to be talking about today is kind of similar to what we did through the group of clinics, but obviously this is more international. But you can actually have a look at the link here and also see the COVID-related material for the Occupational Health Clinics for Ontario Workers. What I thought I'd do, maybe just I might just put it back to Dr. McIntyre, just to kind of give us a quick overview of EpiWatch, and then her book, just to touch on those two things, and then I can carry on with the presentation. So maybe you want to add a bit more about yourself, Dr. McIntyre, what I might have missed, and maybe just provide a bit of an overview on EpiWatch and the book, and then I can get more into it as we go on.
Thanks, Kevin, and good evening. I think it's evening where you are. It's morning where I am. So I am a physician by background, and I sort of my planned career pathway wasn't into infectious diseases research, but that's where I ended up after doing the Australian Field Epidemiology Training Program, which was all about outbreaks and outbreak investigation. And then I just continued from there, and my PhD was on TB transmission, and part of that was in 16 prisons in the US, which was really interesting. EpiWatch is something that was conceived after the West African Ebola epidemic, where we saw in 2014, where we saw the quite devastating impact of delays in responding. The outbreak was known about in March, but really there wasn't a concerted global response till about August. And in that time, it went from sort of 100 cases or so to, in the end, 28,000 cases. So it was, I think there was a lack of understanding in many areas that truly epidemic diseases grow exponentially. So, one case gives rise to two give rise to 4, etc. If it's an R0 of 2. And so you don't have a lot of time to respond, and any delay is really costly, where you end up with a much bigger epidemic, and your chance of containing the spread reduces with each day of delay with true epidemic infections. So we got some funding through a Centre for Research Excellence in epidemic response, and within that, from 2016 onwards, started developing EpiWatch, initially just working on search terms to sort of mine open source data, because people talk about what's happening in their communities and local news agencies report on things. So it is possible to pick up an early signal before health departments know about it. And that's the aim of EpiWatch, not to replace traditional surveillance, which is typically from hospitals and health systems and laboratories. But by the time those kind of notifications are looked at and trends are analysed, usually it's quite late in the piece, and something that's truly epidemic, like SARS-CoV-2, has already spread. By the time the world recognised what was going on in January, it had already spread to North America, to Europe, and so on. There's now serological studies showing that it was already circulating outside of China by January 2020. So, so what we do with EpiWatch, we kept on developing it. Then we semi-automated it from, sort of 2017 to 2018, automated it in 2018, and then kind of ran out of funding towards the end of 2019, which was pretty unfortunate, because when we went back retrospectively, we could have found a signal for unusual undiagnosed pneumonia in Hubei province of China, which is where SARS-CoV-2 started, in November 2019. So we didn't have any staff or any analysts working on it, looking at the data at that time. But then we got another grant in 2020, and that enabled us to really take the work to the next level. And then, so we've got, it's 2 AI subsystems, including natural language processing, and then a prioritization algorithm, which helps to sort out the junk from more valid signals. But we're now at a stage where we can really take it to the next level, and we've got a philanthropic donation from Vitalik Buterin, who is who set up a philanthropic fund called Balvi in 2020. So his fund gave us funding last year and again this year. So that's really enabled us to keep the work going, but also we're planning to open source EpiWatch. And yeah, we have a lot of exciting developments there. I might stop there, and we'll cover the book later, Kevin, because I think
okay. So yeah, sure. So just to let everybody know that Dr. MacIntyre is considered a kind of world authority in this area. This is something that I saw at Sydney Opera House, and she was talking about welcome to the Pandemocene. And I thought, wow, that's the kind of the age that we're in at the moment. We've got to worry about pandemics with everything else coming along. And I thought I'd throw that up there. But with EpiWatch, there's just kind of a screen dump of when you navigate through it. And I haven't really looked into it too much, but when I kind of looked at Episcope, you can actually get a weekly brief. And there's been a lot of discussion about the Marburg virus. So it's kind of like you get this weekly report that gives you an update on all of these outbreaks in different countries. And also, it's not only human, outbreaks, it's also animal outbreaks as well. It's a really useful resource just to get a snapshot of what's going on. So, and you talked about EpiWatch and what it can do. Firstly, is there anything else in the world like EpiWatch, Dr. MacIntyre?
Yeah, there are a few systems. The oldest one is ProMed Mail, which is more a qualitative system where it's been going since the 1990s, and that's where usually clinicians or health professionals report suspicious outbreaks, and they've been really at the forefront of early detection of epidemics, including, I believe, MERS coronavirus. They got the first report of that in 2012. But it's qualitative, so it's not, there's no automation or AI. It's really people reporting, professionals reporting outbreaks. There's another one called Health Map, which was developed also maybe in the early 2000s, which is broad across all health areas, including chronic diseases. That does give open access to data. And they pivoted quite well to monkeypox, for example, or mpox last year. where they set up an MPOX dashboard, which was very useful. But those are the only two that provide open access to the data. We provide open access to the data on our dashboard. I think one of our strengths, there's a few others, but they're commercial operations that are trying to make money, you know, by I suppose getting big corporate clients on board, but they don't provide anything openly. And I think one of the strengths of our system is the languages. So we did a lot of, we've done a lot of research behind EpiWatch, and if you don't search if you search in English and expect, you know, Google Translate or Azure or whatever to automatically translate news in other languages, you miss about 60% of outbreaks. So it's really important to actually search in original languages. So we started by really focusing on Asian languages, Asia and the Pacific, which is our region. And we have every major Asian language, and, you know, including about 12 Indian languages, Thai, Vietnamese, Burmese, you know, and we've got Swahili and Afrikaans in the system. So that it's actually searching for stuff. Like during the Marburg outbreak, for example, we just had a look at the map to see where there were viral hemorrhagic fevers being reported, and we came up with one in Iraq. And if you Google search, you know, viral hemorrhagic fever in English, you won't find anything. But we were able to pick it up because we're searching in Arabic. So yeah, I think that's our great strength, is the language work that we've done to help us really get a comprehensive idea of what's going on.
I think you actually mentioned in your book, from memory, that, you know, had EpiWatch been used more, you know, from the start of SARS-CoV-2, we may have been in a better position. Is that right? Or?
Yeah, the problem is, no, you know, public health is very old-fashioned. We've seen the adoption of AI, artificial intelligence, into clinical medicine and acute care for a long time now. You know, it's very advanced. You can do drug development with AI and cut years out of the drug development process, for example, because you can use computational methods to identify what molecules target what cells most effectively, whereas previously you had to, it was trial and error, and you had to do lots of experiments, and animal experiments and then human experiments, etc., before you identified the right drug targets. So, but in public health, it's still very old-fashioned. So most public health practitioners still use, you know, old-fashioned surveillance and don't really, we've done a lot of research also looking at attitudes of stakeholders. There's a lot of mistrust of open source data, of AI, of modeling and simulation, and it's not routinely used in practice. So, you know, actually WHO has a system called EIOS, which is also an open source intelligence system, but it's not open to the public, and it's only selected stakeholders are allowed access to it. But that was operational and fully funded, and, you know, it didn't pick up COVID early enough to prevent it spreading outside of China.
Yeah.
Yeah.
I think you've just answered that question, just the discussion we've had. So it's great. Thank you. So we might now move on to Dark Winter, and I skimmed through it the first time, but now I'm going through it in a lot more detail the second time. And there's just there's the contents page, and you've got some really interesting titles here. You know, Trust Me, I'm a Doctor, Epidemic Detectives, Brain-Eating Viruses. So it's kind of really novel headings that you've got, chapter titles, I should say. But there was one chapter, Information Warfare. And, you know, if you think about all of the information that we've been given, did you want to kind of explain a bit more about what's in that chapter?
Sure. And I mean, all the chapters are very related. So, you know, Trust Me, I'm a Doctor is about you know, the importance of using critical thinking and understanding that doctors are like any other human beings, you know, they're susceptible to influence and to working towards agendas and not necessarily always telling the truth. And we've seen that during COVID, you know, mainstreaming of disinformation, often by doctors and medical leaders who are pushing a narrative for political purposes, but which is not scientific. And the general public tends to trust doctors. Doctors are a very highly trusted profession. And that's tied to information warfare, which is, and in the book, throughout the book, I use historical examples rather than talking in the abstract about today. I use example after example of where things have really happened, incontestable facts. So to really put it in context and make people think this isn't a conspiracy theory, these things actually do happen, they have happened. And I use the example of tobacco science as one example where the science was showing that tobacco is harmful as early as probably the 1950s, well, the first case control study by Richard Doll and Austin Bradford Hill was in the 1950s that showed smoking caused lung cancer. But it took, you know, a very long time. There was evidence before that. It took about 100 years before it was accepted that tobacco was dangerous. And the reason was there was a very strong concerted effort by the tobacco industry to push counter narratives. Every time a study came out suggesting that smoking was harmful, the tobacco industry would fund willing doctors and scientists to put out some other study that said it wasn't harmful. So you saw this push-pull of narrative, counter-narrative, until finally it was so overwhelming, it couldn't be ignored, and it was accepted. But a lot of people may not realize it took a very long time to get to that point after the damage caused by tobacco was well understood scientifically. And the role of doctors and medical journals in colluding in all of that. You know, medical journals used to advertise tobacco in their pages. Tobacco companies used doctors for their advertising. They had, you know, Camel used one saying more doctors smoke Camel than any other brand. And there were other brands, you know, using doctors to say, you know, this brand is not irritant to your respiratory, you know, to your throat. And so doctors were willing peddlers of misinformation and death, you know, and nothing's changed. You can always find a doctor to peddle anything you want, who'll, you know, take the money and do whatever you ask them to do. And that's the point I'm trying to make. But then I put another more recent example, which is the Nobel Prize winning work of Professors Barry Marshall and Robin Warren, who are Australian researchers. Barry Marshall is a gastroenterologist, and they discovered that the cause of stomach ulcers was a bacteria. And until that point, the whole gastroenterological community had believed that stomach ulcers were caused by stress. And so there was a huge industry in treatment of stress with psychiatrists and surgical treatment of ulcers, and also drugs. So the first drugs to break the $1 billion sales ceiling in the world of any drugs were the H2 blockers. You know, you might remember Zantac. And it was huge business. If someone had an ulcer, they would be on those drugs forever. Whereas if you accepted that it was caused by a bacteria, a course of antibiotics would cure you, and that would be it. So there was a lot at stake, and this was an extremely unpopular finding. And if you, Barry Marshall, I've heard him speak at different events, and he puts up all the rejection letters that he got, you know, where he was rejected to present at conferences, rejected from journals. The whole gastroenterological community, or most of it, really rallied together, including the journals, to block and resist this research. And it was only 20 years later that they won the Nobel Prize. So it took a very long time for that to become mainstream. And, you know, there's a great quote by, I think it's Max Planck, which says that new knowledge doesn't get, you know, I can't remember the exact words, but it's something like, you know, new knowledge doesn't become established because Alzheimer's suddenly accept that this new knowledge is true. It's because they eventually die, and younger people grow up in their careers knowing that this is the fact, these are the facts. And that is true in everything we see. And, there were a lot of people adamantly against this research by Marshall and Warren, who probably had retired by the time that they won the Nobel Prize, whereas the younger medical students grew up understanding that this was what caused stomach ulcers. So there's many other examples in medicine and health where there has been this information warfare, so a push-pull, blocking of something that's inconvenient or an undesirable finding, and elevation and enabling of counter-narrative research to push a different agenda.
Thanks, Dr. MacIntyre. And I'm going to be bold, and I'm going to come on to this anyway. And I'm just thinking about how you've been marginalized, your respirator trials, the biggest trials in the world for decades, continuous use of respirators and very nicely designed studies, why they have been marginalized. I don't know if you want to comment there or just leave that, but it's just
yeah. I mean, I do cover that in the book and in the chapter Fuss About Face Masks. But yes, that research has been subject to information warfare with, the full-on thing from beginning to end over a period of more than a decade now. From about 2009 onwards, where the research has been completely ignored in WHO policies as late as 2012, by which time the two large respirator trials had already been published. And we wrote to WHO and said, why have you not cited our research? You may not like it and you can say what you like about it, but aren't you supposed to cite all the available research? And that was it. So they sent back some, they didn't give an adequate answer, but so it was to that extent. And then, within all the systematic reviews that are done, ours are consistently rated as low quality evidence, whereas other trials that have used pretty much exactly the same methodology, like the Radonovich trial, have been ranked as high quality evidence. So there's such subjectivity in doing systematic reviews and Cochrane reviews. They're not and I talk about that in the book as well, that anyone with an agenda can design any study to support that agenda. And we see it in medicine all the time.
So then moving on, you talk about chapter 11, this title, The Fuss About Face Masks, and you've carried out numerous studies comparing the efficacy of medical masks versus filtering face piece respirators. And I mean, you've shared your experience in chapter 11, and I think you've just given us a kind of a good overview there. And I won't spend any more time on that. But there was a letter, so the study, the multi-center study out of McMaster University was released and it is published. And yourself and David Fissman, who's also a great epidemiologist here in Canada, you challenge the study, and if people want to read it, they can read it there. But there's lots of issues with that study, and then there's also the Cochrane study, physical interventions to reduce the spread of respiratory viruses, and the author's conclusions were kind of fairly obscure, and it's almost like the lack of evidence can be used as evidence. So I don't know if you wanted just have you got any other comments on those two studies?
So the randomized controlled clinical trial, I just recommend reading the letters to that paper, which appear at the bottom of the paper. And there's our letter with David Fissman. There's a lot of methodological problems in the study. The first and the biggest one is their definition of equivalence. So they set out to examine whether medical masks and N95s are equivalent, was it had to be less than the medical mask had to be less than twice as bad as a respirator to be equivalent. Now, what kind of definition is that? What healthcare worker is going to accept that? What doctor or nurse is going to say, that's okay, I'll take the one that's 1.5 times as bad because these people said that's equivalent. It's not equivalent. And then in the way the data was analysed, it was looking like it was coming close to demonstrating that N95s were superior with Canada and Israel, which were the first sites that were included. So the other sites were added later and weren't even registered in the clinical trial protocol, which is, you know, a major problem. And then they added Pakistan, and then they added Egypt even later. So these were at different periods of time with different variants circulating. So the Canadian and Israel sites were recruiting during the Alpha wave, and then, you know, Pakistan and Egypt, Egypt particularly in the Omicron wave. And they also had, you know, an exclusion criteria. If you'd been vaccinated, you couldn't be in the trial in Canada and Israel, but they included vaccinated participants in Egypt and Pakistan. And they said, in their definition, they said you had to be the vaccine efficacy. You had to be vaccinated with a vaccine that was greater than 50% efficacy to be excluded, right? So the people in Egypt and Pakistan mostly got the inactivated Sinopharm or Sinovac vaccines, the Chinese vaccines, which WHO says are greater than 70% efficacious, you know, after 2 doses. So they didn't even meet the exclusion criteria. So you've got largely vaccinated health workers in Egypt and Pakistan, and the bulk of the outcomes, the infections, occurred in Egypt. So Egypt, the results from Egypt are driving the overall results of the trial, and yet, you know, they've included vaccinated people, which is going to, vaccines protect, right? So if you're looking at protection of respirators and masks, you're going to have a highly protected cohort from Egypt, and you won't see those differences as easily as you will. So there were a lot of other methodological problems in those trials, as well as the ethical question of, you know, during a pandemic like SARS-CoV-2, was it ethical to allocate people to a surgical mask?
Yeah, and I think from my understanding that, you know, when Israel wasn't brought into the fold and Egypt, then it was being close to significant. But then when they were brought in, it just muddied the water. And the problem is, and I just think everybody should hear this, masks work, they do work. So don't, you know, be bamboozled by what you read in these studies. And respirators are even better. So, you know.
The other point, sorry, I forgot to mention is, you know, when you've got, and the Cochrane review is the same. It's like just a bad review with lots of methodological problems. You know, the Cochrane name has become tarnished by not just this, but other Cochrane reviews that just use the Cochrane badge to say this is the absolute gold standard truth. It isn't. You know, they've combined dissimilar interventions, and most of the systematic reviews done by these and, you know, their community of colleagues about masks tend to combine all the N95 trials, even though the way the N95s were used in the trials were completely different. So in our trials, the N95s were used continuously while at work, whereas in the old Loeb trial in 2009 and then the Radonovich trial, they were used intermittently. So they were only used when you were, you know, either barrier nursing someone with a diagnosis of influenza or doing an aerosol generating procedure. So you can't mix dissimilar interventions like that. And we did, one of our trials actually compared intermittent versus continuous use of an N95, and only continuous use was protective. Intermittent use and surgical masks were equally ineffective, which is, I believe, what those other trials show, because if you haven't got a control arm and you find no difference, you can't tell whether it's equal inefficacy or efficacy. And then the question of whether they use the interventions intermittently is also extremely grey. There's a lot of lack of transparency in what's registered in the trial, what's been said afterwards, and, you know, there's a lot to unpack there, which you know, is also worth looking at.
And just you know, the editor-in-chief of the Cochrane Library responded, and they did apologise. You know, this wording was open to misinterpretation, and they are, engaging with the authors to kind of revise it. But it's kind of information overload and warfare and misinformation. So
well,
and
I think the point is that all the big news agencies reported masks don't work, right? That was a headline news item: masks do not work.
Yeah.
Well, you can't have it both ways when you're trying to conduct information warfare. You can't say they don't work and then say they work equally well, right? There's like, you get tangled up in knots in the end when you're trying to push these narratives and end up contradicting yourself, which is, you know, some of the authors on this Cochrane review are also authors on the N95 trial, right? At least one of them anyway. So you can't say on the one hand masks don't work and on the other hand they do work equally well as a respirator. You know, hello.
And if you go to, so for everyone on the webinar, you know, Dr. McIntyre and Dr. Grosso and others, Dr. Osram did write this in SIDRAP. So you can go through and you can find the critique of the Cochrane study there as well. So just, you know, back to Dark Winter, you know, it's about, you know, you talk about biological attacks, lab accidents and epidemics and the COVID-19, but obviously there's a lot of other infectious diseases like monkeypox and smallpox that you cover. She reveals, you know, the denial, silence, and cover up. It's quite interesting when you talk about, you know, the lab leak theory. It's actually the book is really easy to read. I found it really easy to read. It talks about quantum advances, you know, analyzing quantum advances, genetic engineering, synthetic biology. But what kind of struck me, a chord with me, you know, you argue that the solution to the existential threat will face from biotechnology. We face from biotechnology will not come from the scientists, but from the community having a voice in the future of the planet. So I just want to, if you could elaborate on that as well. And I'm not sure if Yanir Bar-Yam's on the call. So Yanir, he leads a group called the World Health Network. So that's what it is. It's right. Community people that are concerned about what's going on, getting together and trying to challenge, you know, public health messaging and that. But I'm just wondering, is that kind of what you meant, or what did you mean by that?
Well, I think it's about the power of the people. It's in democracies, right? And I think a good analogy is climate change. We've seen huge awareness in communities because they're seeing the impacts of climate change in their day-to-day lives, either through, you know, extreme weather events or bushfires or wildfires and pollution, bushfire smoke pollution, etc. So people are seeing it. They're being affected by floods, by fires, and so on. And I feel in the last Australian federal election, that awareness was definitely a factor in a change of government, because we had a previous government who were essentially climate change deniers. And then the incoming government were, while in opposition, were acknowledging that climate change is real. So people, and I think that was a huge factor in deciding the outcome of that election. So when there is enough awareness in the community of something that matters to everybody, to their lives, to their livelihood, to their future, I think the power of people being having knowledge and awareness is a very strong force for change. And I don't think that, you know, in the book I use historical examples of real examples of unnatural epidemics, both lab leaks and biological warfare or bioterrorism incidents, where, you know, the medical establishment, the scientific experts denied that it was unnatural at all. And when it was finally revealed that it actually was unnatural, it was covered up for a very long time, often 10, 20 years. And I give example after example. So I'm not talking about COVID. If you start off by talking about COVID, people just say, you're a conspiracy theorist. So what I did was I gave all these historical examples where people can fact check themselves. These things did happen. They were, you know, biological attacks or lab leaks. And yet the medical and scientific community really covered it up and denied it for a very long time. Why is that? well, in the instance of lab leaks, it's because there's huge vested interests. You know, if it turns out that a lab leak caused a lot of people to die, then it could end up resulting in greater regulation and less freedom for scientists. And so that's the vested interest in then denying and covering up those incidents. You only have to look at the American Biosafety Association's catalogue of lab leaks. They are exceedingly common. They happen all the time. But what's changed now is that we have technology that is absolutely mind-blowing, not just in genetic engineering of pathogens and the accessibility of that technology, but also in synthetic biology. So creating viruses from scratch. In 2017, some Canadian researchers created an extinct virus, an orthopox virus, very closely related to smallpox from scratch in a lab. So until then, all the intelligence agencies sort of felt that smallpox being created synthetically was technically possible, but too difficult to do. Well, those Canadian scientists blew that theory out of the water. They showed, yes, you can do it. It's actually not that expensive, and you don't need a NIH type lab to do it in. And that is open access published, right? Which means people can look at those methods. If you know the genetic sequence for variola, you can also create variola in a lab. You don't need to break into CDC or Vector in Russia to steal it. You can make it. So these advances in science now mean that the regulation is of such research, you know, gain of function research and synthetic biology is actually an existential threat. The research itself is an existential threat to human survival. You can engineer anything you want in a virus or a bacteria, drug resistance, vaccine resistance. You know, in about 20 years ago, some Australian researchers accidentally engineered a version of mousepox, which is also a closely related orthopox virus, and they were doing it for good reasons, but they accidentally engineered complete resistance to smallpox vaccines, which are very highly protective against pretty much all orthopox viruses, including mpox or monkeypox. So how to engineer a smallpox virus that's completely resistant to the vaccines? Methods for that are known as well. So it's all out there, this whole push for open access publication. There's like, it's just very one-sided. There's no thought as to what are the risks this is putting out to the community. And we did some other research a few years ago, around 2015, asking people in the community in 3 countries, do you know about this kind of research, dual use research of concern? What do you, and most people didn't even know that this kind of research was happening. When they were given information about what it is and how it's done, most people found it unacceptable, you know. So I think it's time, you know, ultimately, whether the argument is we're doing this dangerous research to make a vaccine for you, well, there's no examples where gain of function research has resulted in tangible benefits to humankind, only risks, you know, and lab leaks. So I think, you know, we're just way behind. We're probably a decade behind cybersecurity in thinking about and managing the risks, and yet the march of technology is relentless. You can buy a lab in a box kit online, you know. Yeah, the accessibility of this stuff is so, the cost has declined exponentially. Those same Canadian scientists who manufactured the orthopox virus came out and said in one of their publications, they showed the exponential decline in the cost of synthetic biology. It's relatively cheap to do it. You can buy the equipment you need fairly easily. You know, the rise of do-it-yourself biology, there's do-it-yourself biolabs all over the world in every major city. They're meant to operate at BSL 1 level, but who monitors it? You know, it's all self-regulated. So there's a huge problem, and it's very much like cybersecurity in that the technology, the bad guys are using the technology and the law enforcement are just playing catch up all the time. You know, they're never on top of it, never ahead of the game, always just playing catch up, where it's kind of like a free for all for the bad guys. And it's the same with this kind of research. It's a free for all at the moment. You know, there's not enough. So I've recently joined an organization called Biosafety Now, and you can just look it up. The website is the same name, biosafetynow.org, I think, which is a group of concerned people, experts and community people who've come together to call for better regulation of dangerous research on pathogens and to reduce the risk of either misuse or lab leaks that could harm human beings.
Great, thanks. So, my kind of take on it is that, if you think of the Spanish flu being 1918, and then since then, the things that have happened, now we've got gain of function research happening, and the risk of, a lab leak, it's so much greater. The frequency, we're getting closer together. So, preparedness, we really need to be prepared more so now than ever. So that was just a comment, but I just think I might just go to the chat box. We've got about 30 minutes left, and I did see Dr. Beret from Quebec. He kind of wanted to know about the Cochrane study, and he said, I would like to know if a comment has been forwarded to Cochrane, and is it possible to share that? So did you want to speak
I
to
think
that?
there's a lot of people that have sent comments to Cochrane, and a lot of people working behind the scenes to try and, putting together responses. So, from my perspective, it's, as I said, they've combined dissimilar interventions. They've lumped everything into the N95 basket when, the majority of the events they're looking at are from intermittent use of N95s. It's like intermittent use of a condom, it's probably not going to prevent pregnancy if you just use it sometimes 20% of the time. It's the same with a respirator. If you're only wearing it 20% of the time, or probably less, according to these intermittent guidelines, it's not going to protect you because the virus is in the air.
Yeah. So what I might ask people to do now is, could you raise your hand if you want to ask a question? I think that might be useful too. There's a lot of comments in the chat, but I don't see any really questions but if you want to just ask a question, then raise your hand, please. Or just show yourself and ask the question.
Yep, so I think there's a comment there from David Metcalf saying about the MACINTYRE respirators that were used in Israel. And those have been rejected by the Canadian regulatory authorities as not meeting the standards for an N95, and yet those were used in Israel. So there's that problem as well with the trial. Yeah.
Thanks, Dr. McIntyre. Ziad, you have a question. You're muted. You try and unmute yourself. You can unmute yourself. Okay. Oh, I see. Could you unmute?
Yeah, he can do it now. Go ahead.
Okay.
Thank you very much. Dr. McIntyre, what is preventing the precautionary principle from being applied in the early days of a pandemic or an epidemic spread that seems to have at least some sort of respiratory component or some sort of asymptomatic component? Why is there such a push on preventing the precautionary principle from being applied with respiratory protection?
Yeah, good question. And I do cover that to some extent in the book. And, in Canada, for example, there was a SARS commission published in 2006, which said exactly that. You shouldn't be arguing about whether it's airborne or droplet. You should be using the precautionary principle. And we saw none of those lessons were learned. It was all just thrown out the window. We saw exactly the opposite happening. WHO and peak bodies arguing against the use of masks. Do not use a mask. You might get acne, and this kind of ridiculous anti-mask statements from really leading people at the beginning. And then I think we saw the sort of uncontrolled epidemics in New York and in Italy and Spain, where hospitals were collapsing and bodies were piling up in the parking lot, in the freezer trucks, refrigerator trucks. And at that point, you know, when nothing else is working and the health system's collapsing, people started using masks. But then you saw that push-pull, the information warfare going on. It's still going on about COVID. You know, most countries have now removed mandatory mask wearing in hospitals. At the same time, there's a narrative about, oh, but we'll protect the vulnerable, you know, we'll protect the vulnerable and the sick. And who do you think is in hospital? You know, it's not the healthy young people, it's vulnerable people. The majority of patients in hospital are extremely vulnerable. And yet here we are saying smiles are back. It's you know, there's huge vested interests at play. Some people, there's a lot of theories as to why there's this huge entrenchment of this anti-mask kind of philosophy, which is what it is. And I do discuss some of it in the book.
I see Ellie Barish has put the COVID emergency was formally ended today in the USA. Audrey, you've got your hand up, then Dorothy.
Yeah. A couple of people said, is there a way to get the book other than through Amazon? And one person said Kobo, and another person said chapters.indigo. I'm not familiar with those, but those are the two they mentioned to get the book without going through Amazon.
Yep, it is available in North America through it is available in North America.
So many of us are so used to Amazon, we don't know of any other way.
Yeah, I think there is one of your websites you can actually go through and get Kobo, and there's different there's a different places you can go to get it without going through Amazon. I'll stick it out, Audrey, and send it through what I use. Dorothy, and then Lawrence.
So thanks very much. Just where to get the book. I figured out where what the publisher was in North America, and I'll find it in my email. I haven't heard back from them, but
yeah, it's
I'll put that in the chat.
The distributor is IPG in North America.
Right. And I haven't heard back from them since I tried, but I'll try again. Thanks. So I too am writing a book about this pandemic with an occupational health focus to it. And the question that I keep getting from people is, so why do these guys, because it's mostly guys, but not, but why do these doctors keep on saying that, you know, evidence isn't good enough, that essentially that masks don't work, that the virus isn't in the air? What is it about their training, was part of my hypothesis, that that makes it so hard for doctors to say I was wrong, or to change their minds or accept new evidence? What are your thoughts about that?
I think there are some. I don't think it's a generic thing. I think it's specific to the infection prevention control community. It's a cultural and ideological stand that community has taken for a long time, going back to SARS in 2003. And in that case, you know the tale of two cities, Toronto and Vancouver, where they both saw their first cases of SARS around the same time. And in Vancouver, health workers were given respirators. They didn't have an outbreak. It was under control. In Toronto, the same arguments prevailed. You know, surgical mask is enough. So health workers were given surgical masks. There was a big outbreak. Lots of people died. A lot less than have died during COVID, mind you. But some people tell me there's kind of maybe political, you know, fear of repercussions around decisions that were made then. And there's an interesting phenomenon called escalating commitment to a failing proposition that's taught in business schools. And, you know, the Space Shuttle Challenger exploding is a good example of that, where NASA was really invested in that launch, and they thought they'd get more funding for NASA, and the management really wanted that launch, but the engineers were telling them, if you launch under these temperature conditions, there's 100% probability the shuttle's going to explode. So what they did was they sidelined the engineers, ridiculed them, you know, minimized their findings and went ahead with their own narrative and went ahead with the launch. And of course, just as the engineers said, the space shuttle exploded, killing everyone on board. And I don't think it resulted in more money for NASA. So that's the phenomenon. So when you're faced with growing evidence, when you take a particular position and you're faced with growing evidence that the position you've taken is wrong, the natural human response is not to say, oh, I'm so sorry, I'm wrong. It's to actually become even more entrenched and fanatical in defending your position. And that's what we're seeing now with denial of long COVID, denial of the serious complications around COVID, including in children, you know, the pediatric community that's become, you know, argued against, not so much in the US, but certainly in the UK and Australia, argued against vaccination of children under 5. There's a huge effort to deny the serious complications in children, which are absolutely on par with other diseases which we vaccinate young children under 5 against, if not worse. But you see this escalating commitment to this proposition, and people just get more and more entrenched, and they create more and more false narratives to support their entrenchment.
Thanks.
You
We're kind of
mentioned
mindful
two
of
cities.
time. Sorry, just
Yeah.
mindful of time.
I was just
we've
going to point out
kind
that Lynn Fiatro was the doctor, and she's on this. She's been making some comments in the chat. She was the doctor involved with the first patient in BC.
Did you want to say something, Lynn?
Sorry, can you hear me?
Yes.
Yeah, I was involved with the first case and in Vancouver, and it speaks a little bit to what RAINA was saying. The day I was on duty in emergency, I happened to catch up my emails, and it was the beginning that the BC CDC, was starting to have a reporting to physicians and clinicians to let them know of any suspicious infections out in Asia, because Vancouver is so close and we have so many of our population that have ties to Asia. And really it was a question of, if you want, the reverse of the Swiss cheese, where I got an email in the morning, I was looking at my email and there's some suspicious pneumonia and also concern of Asian bird flu that might impact us going forward. And the last patient at the end of my shift was somebody who had just returned from the Metropole Hotel in Hong Kong, who happened to be blue and couldn't breathe. And I couldn't get the story initially because we're just resuscitating him. But then it all unfolds because I was prime, I was concerned. And we also were in a teaching hospital, and I changed the way I referred to the services. I bypassed all the medical students and the house staff and went straight to staff communication. And we didn't have isolation room at the time. It was before a big reno, post-SARS. But the charge nurse who heard the story emptied or move the patient out of isolation and put my patient within 45 minutes in a negative pressure room. And from then on, it set the tone. You need to be in isolation. People need to be masked. And all of this, the continuation of the response, we didn't know what it was. I thought it was bird flu. And the story exploded after the weekend that, oh no, it's SARS. We were lucky. His wife did get sick. She did not get hospitalized. But the three of us that were exposed without a mask initially, we were tested for antibodies, and none of us were sick. What was interesting in retrospect is I refused to go get an award and sent my department head and really didn't pay much attention until somebody gave me a book on SARS. And the book on SARS written in Canada had the medical microbiology and the infection control for my hospital taking credit for everything.
Mm.
So very,
Yeah.
and it explains why now that lesson wasn't learned, because they took credit and they
Yeah.
didn't realize that, no, there was a lot of things aligned here to make this response. And I never talked about it except 10 years later, where we had so much overcrowding in our emergency department. And I was married to the person responsible for BC emergency section. And he told me, you got to talk about this. So there was an article finally published where I said in 2013, we could not reproduce what we did, because by then we were seeing people in hallways, in chairs in the waiting room. And if the patient came in, there may not have been even a bed for him. He'd be sent back to the waiting room to infect the entire waiting room.
Mm.
Yeah. So
I think
that's,
that's a great example of leadership and how leadership makes a difference. You know, if you've got someone setting the tone and leading the response, in that can influence everything. It's just, yeah, it's really.
and I think it's true for emergency in general. Emergency department, we are dependent on the team. So there's no prima donna. When you have a nurse who's got 15 years or 20 years who tells you, I know this patient is last on to be seen, but I want you to see him first, you listen. So we have this team and interconnectedness that other departments don't. And so there's less of that prima donna, I'm right. And you get a lot of, you constantly learn. So I think it's a mindset as well. We don't think we're on in general.
Thanks so much for sharing that, Lynn. It's the hour's up, and it's actually 3 minutes past the hour, and I'm just very mindful. It's, you know, RAINA was kind enough to get up at 6:45 in the morning in Australia, and you know it's early, still early for her. So I'm just wondering, maybe we should just finish now and just thank RAINA. If you got, there's two hands up. I don't want to put you in the spot, RAINA, but did you want to answer? Okay, so there's Lawrence and Simon. Maybe you guys can be quick if you don't mind.
Thank you very much, Kevin and RAINA. I just want to add one thing to Lynn's story, and that's that the regulatory agency, WorkSafe BC, had been inspecting hospitals for 5 years and writing regulatory orders for N95 fit testing, which is also a contributory factor to 0 cases during SARS-1 in Vancouver. And in contrast, the Workplace Health Regulatory Agency in Toronto did not inspect at all during those years. The question I had, Dr. McIntyre, is how many cases from retrospective studies were there in pre-December 31st, 2019 in China? Were they in the city or were they outside of the city in the countryside?
The case that I was talking about that we identified through EpiWatch was in Hubei province, but not Wuhan. They were flown in by helicopter to Wuhan to be treated. Other studies have so that the information is very patchy, but there's certainly also reports that people at the Wuhan Institute of Virology were sick at least in November. But there's also reports from the World Military Games, which were held in October in Wuhan, and teams from all over the world came. Interestingly, the US team flew in from Seattle to Wuhan and back to Seattle, which was ground zero for the COVID epidemic in the US. And a lot of the athletes who went to the World Military Games reported a severe influenza-like infection, and they were obviously young, fit people. And I haven't seen any analysis of, you know, anyone looking for stored serum from those athletes. That was taken between October and December 2019. That will be the thing to do, test stored serum that you've got from any of those athletes for antibodies to SARS-CoV-2. But the other thing is there's serological evidence from studies in the US that it was circulating in the US by December. And also from Europe, there's some evidence that it was already in Europe by November. So there's multiple lines of evidence from lots of different parts of the world that it was already spreading.
There's also a case in France, a suburb of Paris, which you're probably aware of. That's a serological sample that was examined retrospectively. And that the gentleman who had those signs and symptoms had no history of international travel. So it seems to me that the virus was circulating broadly internationally prior to the first cases in Wuhan being diagnosed.
Yes, yes.
Okay, thanks.
Thanks,
Oh,
Lawrence.
WHO,
We might go to Simon now. Over to you, Simon.
Thank you very much for a most informative presentation and talk. Thank you. Just a quick question on aerosol generating procedures, in that there's been research during the pandemic, of course, showing that things like coughing, speaking is in many cases far more significant as an aerosol generating process than what has been the traditional concept. I just wondered how you think we need to address that in the future, particularly with thinking of standards and how we address that in guidance that needs to be offered. Thanks.
Yeah, again, I think there's a entrenched belief system about infection occurring after a single ballistic event, right? That's why there's a focus on aerosol generating procedures. Well, we know that study you mentioned shows a cough generates more aerosols than endotracheal intubation or extubation. So, and yet, you know, under many guidelines, a health worker would be only given an N95 if they're doing an intubation, but not if they're treating a coughing patient. But really, you have to think about it as a cumulative aerosol load in the air, which is a function of how many people you've got with COVID in the building, what sort of ventilation have you got, and the duration of time spent in there. And that's really not within the way that the infection control community thinks. They, you know, they still think about it's a single ballistic event.
Yes.
You know, that and it's really cumulative aerosol generation, and the amount, you know, if you're in there all day or doing an 8-hour shift, you're going to be at risk of breathing it in. It's inhalational risk that's the greatest risk. But I think, you know, whilst the occupational hygiene and industrial hygiene community understands that, that's not accepted in the infection prevention control. We're now seeing, you know, we've had leaked data from one of our state health departments showing that hundreds of people died of COVID in hospital after being admitted for something else, right? Admitted for something else, didn't have COVID, they caught it in hospital and they died of it. Hundreds of people. Why aren't the infection prevention community jumping up and down about it?
I guess it takes leaders like you, Dr. McIntyre, to kind of rattle the cage and make, you know, move forward. So on that note, I think we might
Thank you very much. Thank you.
yeah, thanks, Simon. Just really thank you so much, Dr. McIntyre, to donate your time to Workplace Health Without Borders. So this is global, and you know, I really encourage people to get the book, read it, and have a look at EpiWatch, because it looks like a fascinating system, and I think we can really get a lot of great information from that as well. Is there anything else you wanted to say before you leave? And thanks again.
No, thank you very much for joining, and it's been a pleasure. And thanks, Kevin, and everyone else who's been involved in organising the event.
Thanks everybody for joining. Have a good afternoon, have a good evening, good morning, good day.